this. Oh, thank you. Welcome everyone for the recording. Hi, my name is Remy Watts. I am a senior health policy analyst here at the Oregon Health Authority, and I administer the Cost Growth Target Advisory Committee, supporting Sarah Bartleman, my manager, and of course the Cost Growth Target Advisory Committee members. We began these educational webinars as a way to do deep dives into these complex topics that come up during our meetings that we don't necessarily have enough time to talk about in our hour and a half monthly meetings. And this concept of collaborating with other states, collaborating on pharmacy purchasing, has come up a number of times in our Cost Growth Target Advisory Committee meetings. And we wanted to highlight all the work that Oregon is doing to support multi-state collaboration. So we've invited our colleagues here, Trevor and Heidi. Trevor is one of the, Trevor, you're going to have to share your specific title. I'm not very good at remembering all those jumbles of words. They're the managers of the ArrayRx program, which has been around for quite a long time. And without further ado, I will pass it over to you, Trevor, to tell us more about what is ArrayRx and what is Oregon already doing to collaborate with other states in the pharmacy space. Thanks for being here.
Thank you. I also would like to welcome Lita Ivasquez, who's our colleague from the state of Washington. I wanted to make sure that everybody believed me when I said we already have a multi-state consortium doing some excellent work. And I'm fortunate to have started work with this group back in 2017. So hopefully today you'll get a nice background of information about what ArrayRx is, where it kind of came from, and to help us kind of frame up where I'm headed today, I've created a nice little outline slide. So in addition to that origins topic, I'm going to talk a little bit about why ArrayRx became what it has become. And what were the state challenges that we recognized and worked together as states to solve for those issues, and how we created state-backed solutions to support those challenges and remedying those challenges. Talk a little bit about how we go about doing things and what our experience has been to date. And then I'll talk a little tiny bit about current barriers and possible solutions as it relates to the Oregon Prescription Drug Program and ArrayRx expansion. I would love to take questions too. So I'm going to, if you want to use some sort of raise hand function, if that's possible, I'm happy to stop and answer questions if need be. First, though, let's talk a little bit about who comprises ArrayRx. You probably all are aware there's a tremendous political lobby that curtails accountability and regulatory efforts in the pharmacy ecosystem. That was on full display the last several sessions. And I think the ArrayRx team of folks are a group of like-minded public servants, all standing on the regulatory front or some sort of public sector program front. And we're all demanding sound stewardship of tax dollars and the protections we all are seeking for consumers, of which most of us are consumers at some point in our lives of pharmaceuticals. And inside of this group is a fellowship, if you will, that has become the difference maker, quite frankly, as we've journeyed through various challenges in various different states to create and leverage our collective knowledge and our collective aligned mission of being good stewards to find state-driven solutions. So let's just take a little look at where ArrayRx came from. It was created for states by states back in 2003 and 2004, kind of the pre-Medicare Part D era. And we're founded on the discount card program, which was established to try to ensure consumers had access to affordable medications at the pharmacy counter. But we recognized very quickly, as both states set up independent programs, that we were doing a very similar thing in a neighboring state, and said, why are we not pooling that collective wisdom and purchasing power and creating a single program that we both use and leverage and benefit from? And very quickly from that point, when we founded the Northwest Prescription Drug Consortium, we found out that there's all sorts of wonderful things that we can do with respect to pharmacy programs across the various states. So PBM services for public employees is an example of that. Workers' compensation programs like SAFE, the L&I division in Washington State, voucher programs, which a lot of folks, I'll talk a little bit more about them, but a lot of folks in Washington and Oregon benefit from those programs, all of which we're able to leverage and collectively better manage purchasing costs and expenditures by leveraging all of that purchasing power through one vehicle, ArrayRx. So all of these entities that you see, or these additional bubbles in 2006 to 2021, are representative of many different programs recognizing that they needed a solution, came to us, and we were able to work with them to provide a meaningful solution to serve their specific pharmacy benefit need. We recognized in about 2019, 2018 that, you know what, we've done a lot of work that's very, very positive throughout the entire landscape of Oregon and Washington. We're starting to get a lot of attention, and we're being asked to present nationally, and people are now asking, how do we join? And so in 2019, we released an RFP that actually allowed and made provision for us to offer all of our services and programs outside of the Pacific Northwest, outside of Washington and Oregon. And in 2022, that became the reality. And we added Nevada in 22, and last year we added Connecticut, and we're poised to add another state this year to our work. We also recognized that our name was also very limiting, so that's why we rebranded to ArrayRx. So who does all of the work, and who, you know, helps make sure that everything stays on the rails, so to speak? Well, we have the privilege of working with all of these wonderful professionals from various states: Washington, Oregon, Connecticut, Nevada, and over 150 years of aggregated experience in various sectors of pharmacy, benefit management, contracting, or facility purchasing, Medicaid. All of those realms are found within the skill sets and expertise of this steering committee. And we're fortunate enough to be led this year by Lita Ivascus to weekly meet and ensure that the terms of our contracts and the terms of, and all of the programs that utilize our contracts, all of their needs are being met, and making sure that we're performing in accordance to what it states in the contract. I think this just highlights how beneficial it is that when you have a group of aligned individuals, all with the same charge of transparency and stewardship over tax dollars, you can really drive unique solutions that are very, very honed in on, and what other public sector entities are interested in adopting. And frankly, the teamwork and the work ethic that we exude is just so unique. There isn't another entity in this space that does what we do. So why does it benefit to have kind of a diverse set of folks with such rich background? Well, pharmacy services are complex and confusing. If anybody tells you that they've got it figured out, they're lying, because I've been doing this for a long time. All of my colleagues have been doing this for a long time, and we're learning stuff every day, and things change. And so this slide is just to help you recognize that there's just brain dumping 25 reasons that, inject complicated things into how we're going to design a pharmacy benefit, or how we're going to adapt policy, or change a program, or something that will impact a program or policy. And having folks that you can rely on to collaborate with and to use as a resource is super, super unique and not found elsewhere, unless you're going to pay a consultant for those services. So I've already touched on these things. I think it just to underscore what our objectives are as an entity and as a provider of all of these services. We want to clearly be seen as a collaborator in the public sector space. We want to help identify a pharmacy solution for public sector entities, work with them, meet their unique needs, but at the same time, effectively leverage the entire group's purchasing power efficiently and effectively. We also want to bring a level of oversight that validates what we claim to have, right? We want to make sure that we can say to anybody who's asking, here's how we validated our transparency. Here are what our audit rights allow us to audit to. And we have some other unique features built into our contract that are also unique, that include a benchmarking and market check process that happens annually. And that's not seen in the industry very often at all, if ever. I haven't seen it in another contract, actually, to be annual. And then we also want to be a resource. We want to be a resource to other public sector stakeholders, wherever they might be. We want to be their partner, and we want to participate in finding solutions and growing the consortium. We want to do that by offering essentially 5 services, with a 6th being added here shortly in the Medicare space. But clearly we are in the pharmacy benefit management space. We have a number of entities that we serve in Washington and Oregon, and then the discount card being the foundational product. We serve all of the member states with the discount card program. And in Washington and Oregon, we have a voucher program that allows for the Department of Corrections in Washington State to access medications that they might not stock at their on-site pharmacies for people that are coming to pay them a visit initially. And so in order to avoid paying full cost at the pharmacy counter while they're waiting for their wholesaler to ship a supply, they'll go and get a small supply at a much lower cost from a community pharmacy. They also use it as a discharge tool when someone's going back into the community. And they've found that using these voucher programs actually helps recidivism, as well as saving money, because it provides a bridge for an individual to stay on medications that they were stable with inside when they transition into the community. Same is done in Oregon with the Oregon State Hospital. We have a discharge program that allows for community members that have visited the state hospital and are discharging back into the community, a voucher to take to a pharmacy once they've landed in a community, and establish a meaningful relationship with a community pharmacy and get that medication at a much lower cost. We also offer administrative services only. That's what ASO stands for, rebate services. So some state programs, they'll offer a formulary, or they'll have a formulary for a benefit. Where this happens oftentimes is in a workers' compensation situation, where there's a formulary, but there's no ability for that agency to actually collect rebate from a manufacturer for a preferred position of a particular drug. And that's where we can come in and support that public sector entity and provide those rebate services, where for the overall net cost for that agency then goes down because we're able to collect rebate on their claims that were submitted. And then we have Medicaid programs. We have a full suite of fee-for-service and managed Medicaid programs available under ArrayRx. And we're really excited that it's, again, a very unique program on the fee-for-service side. There's not another program out there in the marketplace that has leveraged such a rich advisory panel from various Medicaid agencies around our country to derive our solution that we currently have. So how do we do things? I think it's important to recognize that you have to have a principled approach to working for the public sector. Every public sector wants predictability. They want to know how much it's going to cost. They want to be able to plan. They also want transparency. They want to be able to answer hard questions. And then they want to be able to audit, to trust but verify, if you'll allow me. And so we do this through a fixed administrative fee, and that can be done for any participating program. It can be done based upon paid claim, or it could be done on a per member per month basis. We also establish aggressive network guarantees that is, you're not, the maximum you're going to pay for a brand drug or a generic drug is X. And it establishes that maximum. It does not establish a minimum, and I'll get into that in just a moment. We also have provisions with all of our vendors that we have a most favored nations clause. So they're not going to offer a better position than what they're offering us to anybody else. And if they improve terms beyond ours, they honor that in our contract. Transparency, this includes pass-through pricing. And what we really want to understand, want people to understand there is what a PBM pays a pharmacy, or what we pay the pharmacy, is what will be billed to the program that works with us. And that's really, really critically important. It's important for a number of reasons, but the primary one is we want to be able to audit and be able to see what was paid to that pharmacy, which spills over into the auditability category. But that's what we mean by true pass-through pricing. It eliminates the ability to conduct what's called spread pricing by the pharmacy benefit manager. The same thing applies to rebate pass-through. So all of the rebates that are collected on the claims that are attributable to any group under ArrayRx, 100% of all revenue collected from a manufacturer that are attributable to one of our claims is passed through to our participating programs. That's also a very, very important distinction, the language that I use there. Many PBM contracts I've seen will pass through 100% of rebate. Well, that could mean a whole bunch of different things that leaves out additional fees that were paid to the PBM that are attributable to a claim. And if you want to rewind and listen to what I said a minute ago, you can, but I'll say it again. 100% of all revenue that is attributable to our claims that is paid to the PBM by a manufacturer is shared back 100% to our participating programs. That's true pass-through, and that's true transparency in what is being paid by manufacturers to PBMs in the rebate world. We back that up with comprehensive reporting. We have a reporting suite that's standard throughout all of our folks that we work with. And I've worked with a number of different reporting suites. And ours is by far the most robust that I've seen in my 14 years of state service. Auditability, one of the things that, we're subject to, and every other state and public entity is subject to, is government oversight and state oversight and governance. And we take that very seriously. We have explicit auditability rights to claim level detail on all of our contracts. We also have the ability to perform a market check annually, which is also tied to provisions in our contract that allows us, if we're found to be outside of a very narrow range of market competitiveness, we're able to renegotiate improved guarantees to ensure we remain competitive within the marketplace. And we routinely conduct a financial audit on our partners every year that accounts for the largest chunk of our claims. So a lot goes into how we operate, and it gives everybody that we work with insight into our vision and what we hope to be recognized as, which is the most trusted pharmacy solutions provider in the public sector. And with that, any public sector entity can participate, whether you're a state program, school district, utility district, a city, county, etc. All of those folks are eligible for participation through an intergovernmental agreement to take advantage of this purchasing power and this purchasing vehicle. All right, so let me just check chat here just really quick. All right. Yes, thank you. I'll be mindful of the chat later when I get done. All right, so how big are we? That's a question that I often get. I had to dig through some of my older slides, and I apologize that this isn't up to date. The next time out, I will have one that's up to date. But there are over 775,000 individuals served by ArrayRx, whether they're in a public employee or commercial group or managed Medicaid, facility program, or discount card member. You can see since we started the consortium, we have steadily grown, and we show a really nice steady curve. You can see the little blip there for COVID. But we're on a really good trajectory to continue to grow across the United States. Another question we often get is, so how does this true transparency actually equate into savings? It's nice, you talk about it. What does that actually mean in dollars and cents? And so this graph is intended to be incredibly confusing, but I'm going to try to simplify it for you. If you look at the contracted cost line, which is that black line that stands out when you look at this graph, that's the contract cost, or that's the guarantee. That's the most you will pay. What was actually paid is the green line. And that green line shows, is always less than what the contract cost is. Because in a true pass-through performance scenario, a PBM will establish a guarantee, as I said, that is the maximum, but its pharmacy network, they will negotiate frequently new terms with pharmacies that participate inside of their network across any given geography. And over time, typically, those price points improve and those terms improve for the PBM, and they pass those immediately on in the ArrayRx program. They pass them immediately on. And to give you an idea of what that actually equates to, you look at the blue line, which is expressing the delta between that black and that green line. And it translates to $155 million in additional savings, or overperformance, as we call it, against those guarantees for this time period of 2018 to 2022. I can come back and revisit this if it's confusing to you and try to explain it more clearly than I just did. But that is just explaining that it's really important to understand that what the pharmacy is being paid is what the payer is being billed by the PBM. And there's no spread, if you've heard that term. Another question we often get is, so how does this consortium stuff work? Does it, um, is it comparable for one state to the next? And what about the utilization, which is really, really important to ask, because oftentimes utilization of a particular group can dictate the cost to a particular program. So this is a comparison of Oregon's and Washington's utilization as it relates to the top 25 drugs that were paid for inside of ArrayRx. And you can see that, there's quite a lot of correlation between Oregon and Washington. In fact, if you look, it's pretty clear that most of these drugs are found in each other's lists. And it's important to note that each state maintains its own ability to influence a formulary decision and a plan design. So, for example, Washington's PEB and SEB is driven by the Washington State Prescription Drug or Pharmacy Therapeutics Committee, and creates their own formulary or their own PDL. And so that impacts what that utilization kind of looks like. But the same can be true for Oregon if we weren't as fragmented in our purchasing as we currently are.
Hey, Trevor.
Yeah.
I just wanted to make sure you saw we had a quick question in the chat regarding not the previous slide, but the previous slide on the very confusing bar chart that you were outlining. Are the $155 million in savings
Yes.
throughout the entire participating states across the whole ArrayRx program, or is that just Oregon?
Yes, it's through Oregon and Washington primarily, because in 2022, that's all who is participating, and before Nevada's come online after that, so the fourth quarter. So it's just Oregon and Washington.
Awesome. Yeah. Thanks, Trevor.
Yeah, no problem. Let's jump really quick. The other thing that's important to just recognize is, and we get asked, so, what do we actually get as a public entity if we join the consortium, right? So beyond all the efficiencies as it relates to governance and contract management and any help with policy directives and legislative stuff that you can consult the steering committee on, ArrayRx provides support to all of our plans, and the aggregation that comes with joining together also results in enhanced discounts from pharmacies, meaning better discounts, and also improved rebates. As you can imagine, also, if we aligned formularies, we could also influence more concessions from manufacturers. So this slide just compares Oregon ArrayRx price to a known commercial peer group. I'm not going to tell you who they are, but I just want to make sure you can see in real life what it means to come inside of a consortium that's multi-state compared to just a state program. So it results in roughly about a 17% pricing advantage compared to standard commercial pricing inside of the Oregon marketplace. This next slide focuses on rebates, and I think one of the things that has just grown so much, and you can see by this slide itself, I would say in the last 5 years, we've seen just a huge increase in how much people are getting back in rebates. And I think it's important to recognize that you need to really know what is in your PBM contract as it relates to what delineates a rebate, what constitutes a rebate. And because if you have a rebate pass-through that is 100%, that isn't clear, that includes all payments from a manufacturer that are attributable to your claim, you're going to miss out on some of this revenue. And it's much, much bigger than the discount slide that you just saw a few moments ago. And so 520 million in rebates was collected between 2016 and 22. And, so roughly that's about 100 million a year, right? That, you otherwise wouldn't have seen if you really, or all of it, if you didn't use AwareRx. And then some of you with a keen eye will notice also that there's 587 million billed, but only 523 million shared back or passed through. And that's because manufacturers oftentimes will take a while to pay that rebate. And it can be as delayed as 18 months, sometimes even 2 years before a rebate is paid and all disputes are rectified. But we continue to pass through 100% of all revenue that's attributable to our partners' claims, and that translates into much bigger savings to our programs and as a result. So I think in conclusion, I want to just highlight that I think you can appreciate the rich offering that AwareRx is and what it's brought to Oregon and Washington, Nevada, and Connecticut, and now a new state that we're already enjoying working with. And this multi-state collaboration has forged a unique platform where public sector colleagues can come together, raise issues with one another, seek solutions that have worked in another jurisdiction to work in another, and adapt them to meet the needs from one state to another, essentially sharing best practices, right? And we've demonstrated success in doing that across the AwareRx family, and we do that for free. And that's outstanding, and like I said, not found anywhere else. And we're always constantly looking for opportunities to change and adapt and evolve, because the pharmacy realm does that. It is always changing. It is always throwing curveballs at you. And it's our collective goal, along with our contractor, who's been extremely helpful, and our vendors that have worked with us, to collectively come together and meet the needs to manage costs and increase efficiencies and pass those efficiencies along, or those cost savings from efficiencies along, to all of our members. I think the other important thing to recognize with respect to AwareRx is that I've already mentioned the landscape being very dynamic and constantly evolving. We're very aware of the budget crippling price tags of new drugs that are coming to market. It's particularly in the cell and gene therapy space. And so we're working to develop options for our partners to help manage those high cost therapeutics. We're also continually investigating the different approaches to try to make the supply chain more efficient and pass those benefits on to all of our participating programs. And we're open to other innovations that other jurisdictions have that want to try something new. We'll listen to what they have to say and be willing to work and walk a journey through something that is innovative to see if it has value, and then be able to share that back through the entire AwareRx family of partners. The other big thing that we've really noticed over the last several years is the increase of pharmacy deserts, or the expansion of pharmacy deserts, and the implication that has to pharmacy access across our state, but across the country as well. And so AwareRx has taken a very serious approach to try to figure out how to create a critical access pharmacy network that establishes, at least for Oregon at the moment, but it is being considered to be adopted as an option for all states, to identify pharmacies that are are critical to maintain access to a given geographic location, to make sure that all the people living in that state or region have access to a pharmacy. And so that might mean paying them a little bit differently, and structuring reimbursement a little bit differently to ensure that they remain viable pharmacies and open for business. So what are some of the barriers to growth inside of Oregon? I think that one of the things that stands out, particularly in the discussions between the steering committee and the folks that we talk to in other states, when they're asking, so what statute do you use, or what kind of legal framework do we need? One of the things that stands out as a difference between Oregon and Washington's statute is OPDP's statute, or the Oregon Prescription Drug Program, which ArrayRx is basically operated by, is it's permissive. It allows state entities and programs to utilize ArrayRx versus Washington Prescription Drug Program statute, which requires use of their program unless they can provide adequate evidence that they're getting a better deal elsewhere. So I think that's one barrier to why we haven't seen more adoption of ArrayRx partners in our state. And one unique thing about Oregon and Washington is our statutes permit private sector entities, as described in the statute, to participate in this purchasing consortium, which is rather unique. Also, right now, there's no collaborative space inside of Oregon for regulatory and purchasing agencies to kind of share best practices and share their challenges, kind of like how ArrayRx already does that in a steering committee, but there's no state-centered area where all of these agencies that conduct pharmacy purchasing and regulation actually get together, and more on that in just a minute. There also continues to be multiple purchasing decision makers. So you have PEB and OEB, you have PERS, you have Medicaid, you have a few public health programs that make purchasing, like STI or sexually transmitted infections and HIV and AIDS programs. And you also have the Oregon Immunization Program. Try to stop using acronyms, sorry. And then you also have just limited internal capacity, and the use of consultants goes up, and you have the possibility for conflicts of interest when you do that, for a couple of different reasons. One, it's known and out there in the press that some consultants actually have backdoor arrangements with PBMs, and perhaps some of that analytic capacity and recommendations might not be best aligned with your fiduciary interests. So making sure that there are adequate internal analytic capacity that is leveraged and utilized could be very, very beneficial. The other aspect to that is if you have multiple different consulting firms, they're not taking into the big picture all of the different vehicles. They're just focused on one particular program and providing advice in isolation. So all of these things just continue to allow for continued fragmentation and confetti of the pharmacy space. So solutions for Oregon. One of the nice things that we're doing right now is actually creating a Oregon Pharmacy Policy and Purchasing Collaborative, and that's underway, and we're hoping to get that underway and off the email skids onto the full committee or collaborative space by May. And so we're looking forward to doing that. That will begin to establish an Oregon interstate or intrastate, I guess, collaborative, where we can have some rich discussions and collaboration inside of Oregon itself. Also, there's the potential to consider statutory amendments. As I outlined, the OPDP statute is different than the Washington state language. So being thoughtful about that, and then also considering staffing that is adequate to support the various analytical needs in the pharmacy space for all of the purchasing entities inside of Oregon. So with that, I am trying to keep right on time here. 3 minutes over what I was told I was allowed to take. So I apologize for going 3 minutes over. I'm happy to take lots of questions. Don't be shy.
Thanks for that, Trevor, and the fact that you went 3 minutes over with really relevant and interesting information. We will forgive that. So thank you. And Lita, you look like you have your hand raised, and I hope, am I pronouncing that right?
Yes.
Lita, awesome.
Yes,
Lita,
Lita,
thank you so much.
you.
Yeah.
So I work for the Washington Healthcare Authority, and I just wanted to say in the difference in the legislative language for Washington and Oregon, where in Washington, state agencies have to prove that they could get drugs for a lower cost if they don't join the consortium. When that first came into play, it was an opportunity for the state agencies to come together and talk about how they currently purchase and what's working for them, what's not working for them, and to align with each other. So I think it opened a door to collaborating much more. So I just wanted to make that point.
Kirsten, thanks so much for coming. What's your question?
Thanks for inviting us. This was fascinating. I was very curious. Early in your presentation, you talked about most favored nation language, and I was wondering how often that comes into play. So does it act like a deterrent in other negotiations, or are we kind of freely benefiting from lots of people exercising their negotiating power? And are you notified? I guess, like, how often
How do we know?
and are you tracking it close enough that you're like, oh, the price of
good questions
just went down?
Absolutely good questions. So there's actually reporting that we require from our vendors as it relates to all of their books of business in the pharmacy space that relates to that most favored nation deliverable and performance metric. And we, I have to say that the partners that we have right now, particularly, they're pushing people towards us because our product is more favorable perhaps than what they could offer themselves, right? Because we have already reached a threshold of enough lives whereby some of these smaller groups with like 10,000, 15,000 lives are not going to get, or even 100,000 lives aren't going to get by themselves. Yeah, hopefully that answers your question. I probably gave you more detail than you expected. There's this many people, there's got to be more than just one good question. Maybe I'm just too scary. I have this effect on the pharmacy partners meeting every quarter too. It's like deathly silent.
Trevor, I actually had kind of a clarifying question for you,
Please,
if you
Remy.
don't mind. Yeah, thank you. And most people here know that I am new to this policy area and I'm learning a lot. I'm a committee administrator, not necessarily a pharmacy policy expert, but I'm getting there. I'm working on it. So this is going to be kind of like a basic question that I'm hoping helps not only my understanding, but anyone around me who shares my experience. But so you're talking about I'm just thinking about the interest of the committee and the conversations that we've been having and thinking about like the top 25 most expensive drugs that are in Oregon and Washington and I'm trying to piece together a bunch of different parts of your presentation to kind of like form an interpretation. And you mentioned that one of your barriers is that there are so many disparate purchasers in the state. So it's a little bit more difficult to get people together to like get together that volume purchasing. And like just thinking about like how if we were to improve upon that, like get people more collaborative through this group that you're standing up, like what would the potential impact of that be on the purchasing for the top 25 most expensive drugs? Do you think that like those prices could go lower, or have we hit the floor on what our negotiating power is? And also like, what is the growth that we could see with deeper collaboration between purchasers in the state?
Yeah, I think that you're going to see. So good questions, Remy. And there's like that spans so much. So I'm going to do my best. And if I don't clarify enough, just say, Trev, you got to do better. So yes, do I think we could do better if we had a space whereby we could have state agencies come together and actually learn about ArrayRx, learn about the Minnesota Multi-State Contracting Alliance in Pharmacy, which I didn't talk about today, but it also helps us leverage purchasing power across our state. And if we could come together to really inform decision makers across the state with the expertise of myself and some of my colleagues from the Department of Corrections who have and the Department of Administrative Services, to really inform what purchasing should be like in this pharmacy space, to fully leverage it and to fully benefit from all of these pieces, whether it's administrative cost, right? Because the more people you have inside of a group, the administrative cost is borne over the number of people or the number of claims, right? Because it's a fixed fee arrangement. And that's the only way you're going to pay for it. Well, that administrative cost goes down slightly on a per person or a per claim basis the more people that you have inside of the consortium utilizing ArrayRx, for example. So the administrative cost per program could actually tick down just a little bit if everybody was using ArrayRx services. So that's one way from an administrative side that costs could be curtailed, right? Then if you brought all of this purchasing together and said, okay, where is it aligned in utilization? And to your point, if we got everybody kind of aligned to a top 25 and really honed in on that, you could go to that top 10 slide that I showed, and where it showed like that 17% opportunity. And that's a combination of generating better rebates, because now you've aligned utilization across the entire state's portfolio and said, we're going to use a uniform formulary or a uniform prescription drug list. Same difference, just different words. And now we're able to go to the manufacturers and say, hey, we're going to prefer your drug for this given population. And as a result, we want a rebate that's a little bit more nice than what you gave. And the same goes for pharmacies. If the pharmacy knows they're going to get more business, they're going to be more apt to give a slightly better reimbursement and a slightly better discount. So on all of those fronts, you're going to see improvements, I believe. And the other thing that you're going to be able to do is, if you have a state entity that's collaborating and kind of directing and reading the tea leaves, as you will, of the pipeline that's coming and the market changes that happen when brands go to generic or go off patent and biosimilars come in to challenge biologics in that space, you're going to be able to really in real time shift that formulary at the right sweet spot time to take full advantage of the rebates that are there, but also take advantage of that lower priced generic that might also be entering the marketplace, or the biologic that is basically the generic to the biologic. Okay, the biosimilar is the equivalent to that biologic that is cheaper than that even net of rebate. So you need to have all of these things working for you to not just lower the cost, but to help you effectively manage that cost. Because if you go back and look, I mean, that cost curve is just going steadily upward. And I don't see that shifting downward anytime soon, particularly in the cell and gene therapy space. And I think to the degree that we can come together as a state, but also inside of a consortium like ArrayRx, like MCAP and Fuse, which is Minnesota Multi-State Contracting Alliance of Pharmacy, to really align all of our purchasing power across the entire country. That's when we'll begin to have a meaningful presence at the negotiating table with industry and with these folks that are establishing price points that are literally budget smashing and unsustainable.
Thanks for that answer, Trevor. And I just wanted to point out really quickly, this is completely like policy administer fueled. I wanted to point out that the consortium mandate that Washington has, like people have to purchase through this consortium. Oregon doesn't necessarily have it. I want to share that I can think of at least one example that's really similar in Oregon around, counties have to use a service just like this, and then the state offers it. I'm thinking specifically of home visiting in the early childhood space. Counties are required to contract with a home visiting system organization that meets these certain requirements. The only organization that meets those requirements at this time in Oregon is Family Connects. So there is a similar model for what Trevor is talking about in terms of policy making. And Trevor, one last question in the chat here from Maritza. Do you think other states are picking up the discount gap the consortium receives? I guess I'm wondering about the impact statewide. Do pharmacies write the discounts off? Can you please provide some thoughts around this?
Good question. Thanks for that question. I think that some of the larger states, California, for example, I think, they have significant purchasing power just on their own. They're less apt to collaborate when they have such sweet deals on their own. And so I think that states that are that large and that are essentially just in their own right world economies, right, compared to Oregon, they have a position that's unique and may be equal to or like similar to what the consortium receives, and maybe even better. It would be awesome if they would collaborate with us and overnight make our consortium so much stronger. But there has to be something in it for California, and I'm not sure that they would. I think being part of a consortium our size at the moment is worth their time. However, give me about 5 more years, and I think that I'll get it to that point. That's my goal, anyways. Do pharmacies write off discounts? That's a really good question. So, this sparks an actual interesting question about reimbursement to pharmacies and how we've seen different PBMs be named in session discussions in committees and also in the press, and even in a recent Secretary of State report on the CCO PBM contracts. Pharmacies are hurting. And oftentimes pharmacies sign contracts with PBMs or are in a contract with a PBM that requires them to dispense a drug at a cost to them because they can't acquire the drug. And this happens mostly to independent pharmacies, not chain pharmacies, although it's happening even to chains. And so there'll be a percentage of their business that they're actually losing money on. And we know that we have to do something different, and that's why we're embarking upon establishing a critical access pharmacy network that reimburses those pharmacies differently. We also have a different strategy on how we reimburse pharmacies just generally, so that we're not reducing or getting really aggressive with those guarantees on highly utilized generics, which is where a lot of these drugs are literally priced at just a few dollars reimbursement, and it's costing more than that to buy the drug, put a label on it, and do the clinical part of the pharmacist's work at the pharmacy counter. Like if you're only getting $2 for that script, you're way underwater, right? All the staff time, the pharmacist time to check it, to make sure it's right, and making sure it's just not adequate reimbursement. So that's another strategy that we're working on to mitigate for costs. And if you want to ask more questions about that, you can reach me offline. I'm happy to answer anything and talk for hours about this. Any other questions?
Thanks, Trevor. And it looks like we're reaching the end of our lunchtime webinar. Like Trevor said, any other questions, please feel free to email him, feel free to email me. I'm sure you have our emails in your email inbox. I'll drop my email in the chat just for everyone right now, just in case. .Oregon. Oh, meh. But looks like we're reaching the end, and thank you so much to Trevor and Heidi and Letta for coming to present on ArrayRx. We learned a lot about the history of the program, what it's doing right now, and then also the barriers that it's facing as it expands in the future. And there's a lot of food for thought here. So I'm excited to see how the conversation turns in the Cross Growth Target Advisory Committee. But with that, I guess, any closing words from you, Trevor? Putting you on the spot again.
If you haven't already signed up for a ArrayRx discount card and you live in the state of Washington or Oregon, Connecticut or Nevada, please do sign up for the ArrayRx discount card. You never know when your prescription drug coverage might not cover a drug. Every FDA approved medication is discounted on the discount card. So there's my shameless plug for the day.
That's great. I love that as the last word. We need a shameless plug here. Well, thanks again to everyone for spending your lunch hour with us and the Cost Growth Target Advisory Committee staff. Our next educational webinar will be next Monday, and we are going to be talking about what other states are doing to address cost growth drivers. And then, of course, there's the meeting on Tuesday. Looking forward to seeing everyone there and then.
Thank you.
Everyone have a great Monday. Oh, wait, Tuesday? Great Tuesday. It's Tuesday, one day closer to Friday. Bye, everyone.